Perfect. Warmly welcome.
So good morning, everybody, and dear Professor Osmanjevic, dear Amna, thank you very much for the invitation, and I'm glad to join you. Also, it's this time only virtual. I hope hopefully next time it will be in person to speak about cutaneous lymphoma. I've seen you have a very nice program, most of them about inflammatory disorders, and I'm aware also that the following talk will be more in detail about phototherapy, which is important in cutaneous lymphoma. That's why I will just mention it, and we'll leave the more details regarding phototherapy for the forthcoming expert, Dr. Musli Begovic. Right, I have tried to change the next one. So these are my disclosures. Yeah, so what is important to know in cutaneous lymphoma? It's a wide heterogeneous group. And what you see already clinically, there are different times that we have nodules, ulcerations, and often they look clinically very aggressive, but fortunately they have a biologically they have a good prognosis. And that's why it's very important to know the exact diagnosis of cutaneous lymphoma, especially what type of cutaneous lymphoma it is before starting the treatment and so on. You see here clinically on the left side, upper left side, that what we see are most cases is a case of mycosis fungoides, usually presenting with the early stage, and below some rare cases like lymphomatoid papulosis, where you see the papules on the left. And on the right side, you see two patients who have tumors on the face. The upper one, it's a mycosis fungoides with a tumor stage, which has worse prognosis. And below the picture, it looks like the same nodules, but it's a case of a cutaneous anaplastic large cell lymphoma, which is usually associated with a good prognosis. So you see, it's very important to know what is the exact diagnosis before you are starting the management at all. And of course, it's very important to exclude, especially in the early stage, always inflammatory dermatosis like psoriasis or atopic dermatitis, which could often look quite similar to mycosis fungoides in the early stage. But in these cases, it's very important to differentiate it, especially since we are using biologicals for the inflammatory dermatosis like psoriasis or atopic dermatitis, which in case of the misdiagnosis of a cutaneous T-cell lymphoma can lead to progression and also to the death of the patient. So these are two important points, of course, to have a clear diagnosis of a cutaneous lymphoma, to exclude the inflammatory disease, and then the second step, to know which type of cutaneous lymphoma it is. And you see on this slide, the 5-year disease-specific survival. And you see upper mycosis fungoides usually has an 88% of a 5-year disease-specific survival, so it has a good prognosis. But if you go to the low part, you see the Sézary syndrome, patients who have from the beginning lymph node and blood involvement. We have a decreased 5-year disease-specific survival. And you see you have also some subtypes which are very aggressive, like primary cutaneous aggressive epidermotropic CD8 positive T-cell lymphoma with a 5 years of disease-specific survival of only 11%. And often these patients die within 1 year. So knowing that it is a cutaneous T-cell lymphoma, it's important, but the next step is to know what exact diagnosis, with what exact subtype it is, to know the prognosis and to give the patient also an adequate treatment. In the following, I will focus more on mycosis fungoides because it is the most common subtype, and that's what we usually see in our clinics and also in the hospitals and the private clinics. So once we have the exact diagnosis that it's mycosis fungoides, the next important step is to, like in any cancer, is to know at what exact clinical stage is the patient. And here's something special in cutaneous lymphoma, because you have not only the, like in melanoma, the tumor itself, and second, you look for, according to the TNM staging, for the lymph node and for distant metastasis. No, in cutaneous lymphoma like mycosis fungoides, the clinical lesions and the feature of the clinical lesion is also important for the staging. So for the early stage, like 1A, 1B, you usually have patch and plaques in the skin. And in the advanced stage, like stage 2B, then you have tumors. At the stage, what you see here in the stage 3, you have the erythroderma. And having one single tumor in a patient with mycosis fungoides, it's associated already with worse prognosis, much more than the skin could be completely covered with patches and plaques. So you see it's a completely different biology once you have the tumor. The malignant cells are much more aggressive and usually growing like solid tumors, are not more interested regarding this epidermotropism or the contact with the lung cancer. So the skin type is an essential part of the diagnosis and for the staging. So patch black early stage, tumor stage, erythroderma more advanced stage. And you see the TNM classification, and you see the most important information is written on the right side, that most of the patients we see are in the early stage, from 1A to 2A. So about 71.5% of all MF patients are in the early stage. So this is very important information. What makes, of course, big difference regarding is their survival. So patients in the early stage, like patch and plaques, less than 10%, very rarely progress through a systemic disease, less than 5%. And the 10-year survival rate is about 97%. And if you go to 1B, so if you have patch and plaques, more than 10%, then the progression to systemic disease is also very rare, only 15%. And the 10-year survival rate is 83%. So keeping in mind that most of our patients are older, it is clear that nobody will have a 10-year survival rate of 100%, also without having a malignancy. And seeing this 10-year survival rates in this early stage, then you already know that most patients in the early stage, they don't die because of the lymphoma. They usually die according to other reasons, but they die with the lymphoma. So it's, I want not to say it's like having an inflammatory dermatosis like psoriasis or atopic dermatitis, which are also usually could not be cured and the patient die with these diseases, but they have a very good prognosis. And this is very important information to have to give to the patient in your first talk from the beginning, that they have usually in the early stage very good prognosis. On the other side, patients with the advanced stage, like here, the man with the tumor stage, they have often progression to systemic disease, very often lymph node involvement, and sometimes also other organ involvement. The 10-year survival rate is reduced. So you have to keep this in your mind once you start to go to the next step, is to treat the patient. That's what we have for the treatment. You see in the early stage of the patient still phototherapy, UVB, UVA, PUVA, it's still the first line treatment what you use in the early stage. There is no real change. You have, in addition, possibility to use topical chemotherapy, which I will show you, but the phototherapy is still the domain of the treatment of patients with mycosis fungoides in the early stage. And in the later stage, you can add systemic treatments like retinoids, bexarotene, also acitretin, interferons, as a combination or as a monotherapy. And in the recent years, I want to show you just briefly, we have the ability that to use, beside chemotherapy, also antibodies, like the antibody against the CD30 molecule, brentuximab, or the antibody against the CCR4 antibody protein, which is mogamulizumab. And always keeping in mind when you use these systemic treatments that most of our patients with mycosis fungoides are in the older age, so older than 60 years, and often have comorbidities, have other systemic treatments, which should be considered when you use systemic treatments like, as an example, interferon or retinoids like Bexarotene. And now I will go with you through the treatments according to the stage, focus more on the early stage because we most often see this patient, as you see in the left picture, patient having a disseminated patch, and you see the patches are a bit brownish, a bit red, erythematous, and you see also clinically the atrophy, so it's like cigarette paper, and this is very typical for the early stage, which have to be considered as a differential diagnosis for atopic dermatitis, psoriasis, Cutaneous rubra pilaris, or also for Tinea corporis. And once you see the histology, you see that you have a very superficial infiltrate. It's epidermotropic. The malignant cells tend to go in the epidermis. They usually search the contact with the Langerhans cells, which are presenting antigens. We still don't know which specific antigen is the reason for this, but they still act like in an inflammatory disease. And because these cells are first superficial and second can be immune modulated, skin-directed therapies are usually the treatment of choice in this early stage. For this, we have, as I mentioned, the phototherapy, like the Pruba or Neuroband UVB, and we can add also or use topical clomidine gel as a local chemotherapy, of course, in combination with topical corticosteroids, or what you can use also is local radiotherapy in this early stage. So that's what we have. These are what we use, which is very common for all dermatologists. Phototherapy, and then localized treatment with topical clomidine gel or topical corticoids, which cannot be also combined, or if needed, for localized superficial radiotherapy. I will go on more now to what we have got in the last years, which is the topical clomidine gel. It is local chemotherapy. It's an alkylating drug which alkylates the DNA bases which leads that they stick together. And because the DNA bases are stick together, the DNA could not separate what is needed for mitosis. And that's why the cells could not divide, and then this malignant cell goes to apoptosis. And you can use it once daily, or you can use it every second day in combination with topical steroids, which I usually recommend. And with this, you can get for early lesions, for in stage 1A or 2A, 1A or 1B, very good clinical results. Usually, you see the best effect after 6 months, but you see also results after 4 to 6 weeks, like in this patient here. Localized superficial radiotherapy with in low dose, like something like 2, 4, or 6 gray, is very helpful especially if you have unilesional or single lesions of mycosis fungoides. Our colleagues from Harvard, they believe that once you use it in the early stage, you could also heal the patient, and because they showed molecular biologically that this treatment is eradicating the malignant T cell clone. I think for this idea regarding healing, we need more experience, but of course, what we can already say, it's very effective in this early stage. It's an alternative to phototherapy, especially if you have only single lesions. Second-line treatment in the early stage, based on our recent UTC recommendation, is once the skin-directed therapy alone is not that effective, you can add a systemic treatment like retinoids or interferon, or other methotrexate, which is also possible, like low dose, 50 milligrams once weekly. And if you have a more refractory lesions, you can also use the antibodies, mogamulizumab or brentuximab, or, which is also very effective, it's a low-dose total skin electron beam therapy. I will go more in detail to two systemic drugs, which is one the interferon and the other one are the retinoids. Interferon, we have a very long experience, and with interferon alpha, we could add a high remission rate in the early stage till 96%. And it's a very good combination partner, let me say, for phototherapy, especially like PUVA, which could lead to lower cumulative UV dosage. Unfortunately, the interferon alpha is not more available, and the only thing that is available is a pegylated interferon alpha. For this, we have in the last 2-3 years several very good papers. We have 1 month ago, very good UTC paper, and we show that it's very effective. And the recommended dosage is 180 microgram once weekly. Regarding retinoids, especially approved for CTCL, it's the bexarotene, which shows also in combination with phototherapy, very high response rate, about 65%. However, you have to know once you give bexarotene, it's associated with two very common side effects. One is the elevated triglyceride, and the other one is the suppression of the thyroid hormone. So you have to take this in consideration, and always before you start bexarotene, you have to give lipid-lowering drug like fenofibrate, and once you start bexarotene, you have to do also substitution of thyroxine, which is established from this management paper, which we have published with our colleagues in 2006. And we have one study regarding combinations. So in general, we have to say regarding combinations, we have not that much clinical trials, but we have one trial published in 1998 from Rudi Stadler and colleagues, which compared PUVA with interferon compared to two systemic drugs without phototherapy, like interferon and acetylene. And the main information from this paper is that PUVA and interferon works better than the combination of the two systemic treatments as interferon and acetylene. And the side effects are nearly the same if you look to the combination of interferon and PUVA and interferon and acetylene. They are not that big difference. So coming to the end of our early stage patient, like this. So we have in this patient, we have disseminated patch. We don't have tumors. So it's mycosis fungoides stage 1B. And the question is, what treatment we would recommend for this patient? As a topical corticosteroids or clomidine gel, starting with topical retinoids if it's available. In the States, it is available, the topical bexarotene, in Europe not. And what to start regarding phototherapy, UVB, PUVA, or PUVA combined with pegylated interferon or retinoids. And for these cases, nothing changed. Still, PUVA as a first-line treatment is an excellent choice. And if PUVA alone is not sufficient, we can add systemic treatments like pegylated interferon or retinoids. So this is for the most parts of our patients which receive mycosis fungoides, which have usually early stage. And in the last minute, I just want to give you an idea what we can do with the advanced stage patients. For this, as I mentioned, we have the two antibodies, and of course we have chemotherapy. When we use chemotherapy, we always recommend use only monochemotherapy, and which is very effective, it's also the total skin electron beam radiotherapy. Here is a study of our German Cutaneous Lymphoma Network group, where we could show that low-dose gemcitabine, so less than half of the dosage, it's very effective in these advanced stage patients, like the patients with ulcerated tumor nodules, and also regarding progression-free survival, with the reduced doses, which is shown here in the red curve, you have a better progression-free survival than once you use the normal high dose, which are used by the hematologist. And I think the most important reason is the patient with a low dose gemcitabine usually have less side effects, so that they can normally complete their 6 cycles compared to the patient with a high dose gemcitabine, where only about 30% are completing the 6 cycles, and the other one stop it prematurely because of the adverse events like opportunistic infection. Total skin electron beam, very well known for more than 20 years, but it's getting more and more important because we have learned that when you use it with low dose, only 12 gray at all together, it's very effective, and what is important, it's well tolerated. And you see on the left with the water plot, with a low dose total skin electron beam 12 gray, that most of the patients are responding, more than 95%. And you have also ongoing response. So median time to progression was 71 weeks. We use it often, meanwhile, as a combination therapy. Once we developed it in our hospital 6 years ago, we started, of course, with as a monotherapy in these tumor patients, where you could see these very nice responses. And what we have learned in the last years is also if you reduce the dosage from 12 gray to 2x4, so by 8 gray, it's very effective. And this hyperfractionated 8 gray low dose total skin electron beam is meanwhile the standard in our hospital. Coming to the antibodies, here fortunately we have 2 antibodies which change completely the field of the advanced stage, but also of the refractory early stage of cutaneous T-cell lymphoma. We have the 2018 approved the brentuximab vedotin, which is against the CD30 molecule, which is expressed in nearly most types of advanced stage. And we have the mogamulizumab, which is against the cytokine receptor 4. Let me start with the mogamulizumab. The cytokine receptor 4 is expressed in 2 important types of cells. One, of course, it's the malignant cells itself, the MF cells. And so we have bringing the cell in apoptosis, the malignant cell. And it's also expressed on the T regulatory cells, which usually decrease the anti-tumor response. And once you deplete these T regulatory cells, you have an enhanced immune response. That's the idea. Just to show you some examples here, a patient with a long-standing Sézary syndrome who got all the known treatments before, like extracorporeal fluorosis, interferon methotrexate, retinoid, like acitretin, and you see the patient. We treat him with mogamulizumab, and he's very stable. So especially if we have a patient with blood involvement, patient is very responsible to mogamulizumab. And the second antibody with the brentuximab vedotin, targeting the CD30 molecule, which is expressed on the surface of the most malignant cells, mycosis fungoides, and the drug is then internalized. It's an antibody drug conjugate, so it's conjugated with a toxin, which is monomethyl auristatin A, which inhibits the spindle apparatus. So cell is also possible to do mitosis, and then it's got some apoptosis. And once the cell died, the drug itself, the toxic substance, is also in the environment of the malignant cells, so it can also kill like tumor-associated macrophages and other cells. And yeah, CD30 was the first time described by Harold Swine in 82, who was the supervisor of my PhD thesis. Coming to the results of a large trial, where you compared this brentuximab to the standard treatment like methotrexate or bexarotene, and you see the response rate is about 4 times higher in brentuximab vedotin compared to the standard treatment like methotrexate or bexarotene. And with this drug, we can especially treat very well patients with an advanced stage, like patients having tumors. Like here, this is a patient from the clinical trial, or here, that's a patient for paper from the States. And what we learned also in the last years is that the amount of CD30 expression is not that important for the response of brentuximab vedotin. So also if we have single cells which are CD30 positive in the tumor, the patient has a very good chance for a very good response to the brentuximab. And at the end, I just want to show you the future, which we already started. Since we have now very effective antibodies, we have the total skin electron beam, we have the very effective low-dose chemotherapy with gemcitabine. We have the possibility to combine. And is exactly that what is going on in the clinical trials. It is combination therapy. It's something what we are used to do also for inflammatory dermatosis like psoriasis. And now we are starting studies for this. And here, an experience from our hospital here in Krefeld, Germany, where we combine low-dose total skin, so at 8 gray, so 2 times radiation with 4 gray day 1 and day 8, combined with brentuximab in the normal dose. And these were our first 4 patients. And you see on the left, between the left picture and the middle picture, it's only 1 week. And with 1 week, you see already very fast and good response. And the right picture you see after 8 weeks. Meanwhile, we have treated over 15 patients with this regimen. And we see very good responses and also ongoing responses. This was our first patient in tumor stage mycosis fungoides, who got, before the diagnosis was made, dupilumab again before, because they thought it could be atopic dermatitis. And with this dupilumab, she developed from this black type lesions within 6 months tumor stage of mycosis fungoides. She was treated with this combination brentuximab and low-dose total skin electron beam, and she's still under complete remission with a maintenance treatment of 15 milligram methotrexate once weekly. So I come to the end, and I want to summarize. Still, the most important point, once you are dealing with cutaneous lymphoma, you have to define the right diagnosis, and especially in the time of biologicals, where we have learned that dupilumab can lead to advanced stage, to progression of mycosis fungoides. It's very important to differentiate, is it really cutaneous lymphoma or is it an inflammatory disease? If it's not clear, which could happen in the early stage, don't give biologicals like dupilumab. So then go to standard treatments like phototherapy and retinoids and so on, which could be effective for both. But do never start with the biological if you are not sure that it could be not a cutaneous T-cell. So once you have differentiated the inflammatory disease for cutaneous T-cell lymphoma, then you will have to define the exact type of the entity. Is this mycosis fungoides? Is it anaplastic large cell lymphoma? Is it mycosis fungoides, or is it erythroderma with blood involvement like Sézary syndrome? Of course, we have to define the stage. In the early stage, first line is still skin-directed therapy, especially like phototherapy, which we'll hear now more in detail from Dr. Muski-Begovic. And in the second stage, in the early stage, you can use the combination skin-directed therapy. You add systemic treatment like interferon or retinoid or methotrexate. In the late stage, if you are not treating or have experience to use this chemotherapy or the antibodies, then you have to consult hematology. Otherwise, we have effective systemic treatments, especially with the 2 antibodies, brentuximab vedotin and mogamulizumab, and also the combination with total skin treatment in our hands, which we can use for our patients. And by this, I'm at the end, and thank you very much for your attention, and I'm of course open for questions. Thank you.
Thank you very much. Thanks a lot. Do we have any question, a short question maybe? Leila, do you hear us?
Early stages, because borders can be very tricky to get the right diagnosis. We can have clinical like what about it, but then histopathologically, to give proof that it is, it can be something challenging. What is your experience about it?
Oh, thank you. I didn't get it that good. Anna, maybe you can repeat.
But it is how to deal with the challenge that clinical and histopathological correlation is quite low. What is your experience, and what do you think when you have clinical clear presentation, but the pathologist cannot confirm diagnosis?
Thank you. It's a very important question. Thank you so much. So the pathology, it's in dermatology, especially, it's in inflammatory dermatosis, the same as in cutaneous lymphoma. Without clinical correlation, you have nothing in your hands, especially in the early stage. You always need the clinical correlation. So what we are doing, we have the microscope, we have the slide, we have the computer, where we have the photography of the patient at the same time. So we look to the microscope, we look to the clinical picture. And if we are not sure about it, that's what I learned from my old professors. We go to the ward, if the patient is in our clinic, and visit the patient. But the clinical correlation is important. And if you are not sure, especially in the early stage, you can use, in addition, the T-cell clonality. So if you have a T-cell clonality in combination to the clinical picture and the histology, and you find a T-cell clone, it could help you, especially if you have taken in the early stage at least 2 biopsies, where you have twice 2 histologies, and where you also can do T-cell clonality from both biopsies. So if you find T-cell clone which is identical from both biopsies, combined with the clinical picture and the histology, then we have a good chance also for the difficult cases. And if this is not possible, which is also real life, then you can give only suspected diagnosis, and then you need a close follow-up, then you need re-biopsies. But these are exactly the cases where you should not start with a biological treatment as for atopic dermatitis or psoriasis. And we know, since these patients have a usually very good prognosis, we have the time for the follow-up. We are not in a hurry to give a diagnosis which we are not 100% sure, or to give a treatment where we are not 100% sure that we could harm the patient by this treatment. Yeah.
Thank you very much. Only one short question. What is your first-line treatment for Sézary syndrome?
It's regarding our guideline, it's extracorporeal photophoresis. Usually I combine it with pegylated interferon. If it's possible to the comorbidities of the patient, and if not, then I combine it with retinoid. And here I usually prefer acitretin over the bexarotene, because the management for this old patient is much easier regarding the side effects. And second line, I very early give mogamulizumab, because it's very effective for the malignant cells in the blood.
Thank you very much. Thank you again, Chalid. And fortunately, you can see us, but you are welcome to stay with us if you have some time. Otherwise, we have to move to, as you introduced, to our next speaker. And thanks a lot. So I have to actually to end record. I think so. We can do this way. Perfect. Thanks a lot.